Good morning, good afternoon to all of you as you are in the place where it is morning or afternoon or evening. Welcome to the AFOMP School webinar. We have started the AFOMP School webinar in June 2021 in addition to monthly AFOMP webinars which were started in June 2020 after the COVID has started. Because the education cannot stop, education is a continuous process, and we went for a virtual mode. This year's second AFOMP School webinar is on medical physics and nuclear medicine physics and beyond, and this will be given by four eminent speakers, four eminent the nuclear medicine the scientists. The first is the spectrum of information in nuclear medicine, and this talk will be delivered by Dr. Anshu Rajnish Sharma. The second talk in this AFOMP School webinar is being delivered by Dr. Pankaj Tandon, and this will be on unusual incidents in nuclear medicine and reporting mechanism, how to report all these incidences. And the third talk is Dr. S.C. Kheruka, and he will be speaking on quantification methods in nuclear medicine. And the fourth talk will be role of artificial intelligence in precision oncology, and this will be given by Ashish Kumar. And as you know very well, these AFOMP schools are of 2 to 2.5 hours, and our speakers, as I talked to you, is Dr. Anshu Rajnish Sharma, who is Dean, Indian College of Nuclear Medicine and Head Department of Nuclear Medicine, Kokelaben Hospital and Research Center, Mumbai. Thanks to all the speakers. Thanks to Dr. Pankaj Tandon, I have put a request that can you arrange one AFOMP school on nuclear medicine, and he has come forward. He has talked to all this eminent speaker, arranged this AFOMP school. So on behalf of AFOMP and on my own behalf, I thank Dr. Pankaj Tandon, all the speakers for making this to happen. With this short introduction of Dr. Anshu Rajnish Sharma, who is a very active and he has a lot of contribution to nuclear medicine, I will hand over the floor to Dr. Anshu Sharma for first talk. And during this talk, if you have any questions, any queries, you can type into the chat box. We will collect all these questions and try to put to the speaker so that we have a fruitful discussions. All the participants, for a good bandwidth, please put off your videos and mute yourself so there will not be any disturbance. With this short introduction, I invite Dr. Anshu Rajnish Sharma for his talk. Floor is yours, Dr. Anshu Sharma. Now you can share your PPT and continue your talk. Thank you very much. Welcoming all of you.
Thank you, sir, for introductory note. Now I'm sharing the screen.
Yeah, got it. At least visible to me. Fine.
Good morning and good noon for everyone who is now logging to this webinar. Today's topic is spectrum of nuclear medicine instrumentation. Thank you, Arun sir, for nice introduction and giving us opportunity to speak the audience from Asia. Sir, nuclear medicine basically is a technology-based specialty of medicine where the radionuclides are used, rather we can say administered within the patient to diagnose the disease as well as treat the disease. It is different from radiation therapy, that in radiation therapy, the radionuclide source is either outside the body or it is placed in the organ of interest or implanted in organ of interest. So the source is outside in radiation oncology, where in nuclear medicine, radionuclide is administered within the body, either orally or intravenously. And the radiation is actually emitting from patient. So patient becomes radiation source. You can see this is the body of the patient, and radiation is being emitting from the patient body, various organs, and then you have this imaging instrument which perceive each event and localize it and make an image for us or measure the quantity of each event and how much is the activity within the body or which area or organ of the body is localized this radionuclide. Actually, radionuclide do not have a property of organ localization. It only emits either beta or gamma radiation or positron. These gamma or high energy gamma radiations basically gives you image, and beta gives or is being used for therapy. Now, this source of radiation, as we said, radionuclide, it does not have any property to localize a particular organ. So how they go and localize to a particular organ? Because radionuclides are labeled with ligands of pharmaceuticals. These pharmaceuticals are basically inert, physiological. They go to a particular organ and takes the radionuclide along with that. For example, if we are doing a bone scan, the methyl diphosphonate is a ligand. And if we label it with technetium isotope, so technetium MDP goes to the bone, and that causes a bone scan that enables the bone scan. Similarly, if we inject DTPA along with the technetium isotope, the DTPA is a filtering agent through the kidneys. So technetium labeled DTPA is used for the renal scan. So basically the function of organ imaging is by the pharmaceuticals. And when we combine them with radionuclide, it is called radiopharmaceutical. You can see here, it is a one component radionuclide, another component is pharmaceutical. In a radiopharmacy lab, which we call it the hot lab, these both are combined and this becomes radiopharmaceutical, ready for injection. This is the kit and we can inject into the patient. So this is radiopharmaceutical. We have large spectrum of radionuclides now available. With the advent of technetium from molybdenum technetium generator in 1960s, the fast evolution of nuclear medicine has occurred. There is a parallel growth in radionuclide and radiopharmaceutical along with the new instrumentation. So this is the spectrum, which is the long spectrum, and new radionuclides is being added frequently, and it's a long list where there is a technetium, iodine 123, iodine 131, thallium, gallium 67, gallium 68, phosphorus, fluorine 18, strontium 89, rubidium, lutetium, and samarium. That so on is a big list. Now, as you understand, nuclear medicine has two components. One, radionuclides, which we inject or give orally to the patient. And another important component is instrument to measure the distribution of radionuclide within the body or within the organ. So instruments are very important component of nuclear medicine. Now, if we see the types of instruments used in nuclear medicine, we can categorize broadly in 4 types. Like first one is radiation dose or dose rate measuring instruments, then radionuclide producing instruments, then there are probes, and then imaging instruments. Now, this is very familiar with you. When the patient is administered with radioiodine, admitted in isolation ward, then after administration of the oral dose of radioactive iodine, you measure the dose from the organ of interest, that is the thyroid. It is a it is the servometer, which is ion chamber based servometer, which is used for measuring the dose or dose rate from the organ of interest, and at the time of discharge, whether the radioactivity has fallen below the permissible level is measured. This is very familiar instrument with all of you. Now, there are many servometer and contamination monitors which are used for radiation safety purpose in nuclear medicine. They are GM counter based or ion chamber based. You are very familiar with these instruments, are routinely used for checking the contamination and dose rates. Now, this is the dose calibrator. This is also an ion chamber based apparatus. Like any medicine which we give to the patient, it should be measured and it should be given in right optimal amount. So is the case with the radioactivity. If we are administering a particular radiopharmaceutical, it should be measured and it should be given to that particular scan or particular individual based on his age and the weight. That radiopharmaceutical should be measured in dose calibrator before injecting into the patient. And there are various formulas, even pediatric formula is there. If pediatric patient is there, how much dose that particular baby we have to administer, and that administered dose has to be measured here before injecting into the patient. Now, second type of instrumentation is radionuclide productions. Many isotopes are produced in reactors, but the reactors is the beyond capacity of the hospital, whereas the medical cyclotrons are present in few of the larger hospitals in various countries. So medical cyclotron can be 13 MV or 18 MV or 30 MV. Various MV cyclotrons are available. Even baby cyclotrons are available, where a stable nucleus is bombarded with charged particles like electrons, protons, and neutrons, so that artificially produced radionuclide is produced, which is useful for medical purpose or nuclear medicine. So this is a very important apparatus or machine which is present in many of the hospitals, where in the vicinity of the nuclear medicine cyclotron, we have a medical cyclotron facility where every day morning there is a bombardment, production of various medical radioisotopes like thallium, iodine-123, and commonly nowadays is fluorine-18. With the advent of molybdenum technetium generator in 1960 in Brookhaven National Laboratory, the nuclear medicine has kicked off in the medicine world, along with the discovery of Angel's gamma camera. So if this generator would have not been discovered or not been introduced, probably nuclear medicine would have not taken this shape today. So this is the most commonly used isotope, which is the technetium, which is produced or it's separated from molybdenum technetium generators. So generator is basically a system where the daughter product in which we are interested, which is interested of medical interest, is separated from its parent compound. The molybdenum decays into the technetium, both are in the same solution, and by passing a normal saline in alumina column, this is a simple example where the alumina column is placed here, and the parent molybdenum is soaked in the alumina column, and we pass normal saline, and you can see the drop is getting separated. This is the technetium which is separated from its parents molybdenum. This looks simple, but these generator systems are very lead covered systems which are very stable, which are supplied every week in the nuclear medicine department. And these generators are basically can be divided in two types, wet type and dry types. Wet types are very less often used nowadays, where the normal saline collectible was present within the generator. And you can just set the volume, how much volume of technetium you need. You just set the volume, and then the desired volume comes in that, the technetium comes in the desired volume after elution. This process is called elution when you separate technetium from molybdenum. This is done every day in the morning, and after 24 hours, the daughter technetium again builds up to this maximum capacity, and in next morning, again we separate technetium for the molybdenum. So it is very important generator system for the nuclear medicine function, and it is called COW, because it is a main workforce of nuclear medicine department, 80% of isotope used in nuclear medicine is technetium. Now, another generator is dry tech or dry type, where you put a normal saline volume, how much normal saline you want to, the technetium volume you want to elute. This vial normal saline is put on this port, and this is sucked into the alumina column, and the technetium comes again and get collected in this vial, which is covered with the lead. So this is dry type and wet type of generator systems. Nowadays, many nuclear medicine departments have germanium gallium generators in their facility. The gallium is a PET tracer, which is labeled with various ligands like PSMA for prostate cancer, Exendin for pancreas, and the Dotanok for the neuroendocrine tumor. So there are various ligands which you can label with gallium, and that can be injected. That gallium generator is present in the department. You can elute the gallium, label with various ligands depending upon your requirement. So commonly used are nowadays Dotanok and PSMA for prostate cancer. Now this is an automatic synthesis system. And here you can see this is the generator, germanium gallium generator, and this is automatic synthesizer, and this is the automatic cassette used. Very small, on a 3x2 table, you can keep it, very small generator, which is commonly present nowadays in the various departments. Other than these two generators, you can have rhenium generators, which is also used for therapeutic purpose in various diseases like liver tumors or for bone palliation. And another is rubidium 82, which is very, very costly, and it is imported, and it is used for the PET-based myocardial perfusion scan. So there are various generators which are present in current nuclear medicine departments. Now comes to the thyroid probe. The basically functional assessment of nuclear medicine started with these probes, thyroid probes. The thyroid probe is used for basically to assess the function of the thyroid gland. You can see here, there is a sodium iodide crystal, we call it a scintillator type of detectors. Then there is a PM tube, and this is a preamplifier, and this is the output cable, and this is the collimator. So this is facing the neck of the patient after administration of radioiodine. A very trace amount of radioiodine is given to the patient in a capsule form, and then uptake measurements are done after 2 hours and 24 hours to see whether thyroid is taking increased uptake of radioiodine tracer or not. If there is an increased uptake of the tracer radioiodine uptake, then it is hyperthyroidism. So this is very commonly used for diagnosing as well as for therapeutic purpose, but its use are now it's now less used or less oftenly used because of the advent of now modern day gamma cameras. Now there is another type of gamma probe which is used is intraoperative gamma probe. During the surgery, this is handheld probe which is used by surgeon to localize a particular organ or tissue where the isotope is being localized in hyperconcentration. So it is very commonly used for detecting sentinel lymph nodes. When we are doing a breast surgery, the surgeon, we inject radioisotope like technetium collide into the within the tumor or around the tumor in the breast, and then we see how this radio tracer is being migrated towards axilla, and this isotope, the collide particles get concentrated into the lymph nodes. The first lymph node is called sentinel lymph node. So during the surgery, now surgeon, when he's exploring the axilla, with the use of this handhold probe, he see which is the first node which is showing maximum count. It means it is a sentinel node. He takes out that sentinel node, and histopathology examines for the malignant cell. If there is no malignant cell present in the first node, it means there is no need for dissecting the axilla. So a surgery which causes lot of lymph node dissection, unnecessary lymph node dissection, and then causing lymphedema to the patient can be avoided if first lymph node, which is called sentinel lymph node, does not have a malignant cell, which is detected by this handhold's intraoperative gamma probes. You can see the simple diagram to show its mechanism. Now here is the simple detectors. It can be either scintillator crystal or it can be semiconductor type of detector. This is a probe, and this is electronic circuitry, and this is the handle, and this is the counter system. So if you are seeing the axilla, where is the maximum count is coming. It means that is the node which is concentrating the highest isotope or colloid particle. That node is dissected by the surgeon, handed over to the pathologist to see at that in the surgery, in the surgical theaters, to see whether it has a malignant cell. So very important nowadays, gamma probe, every nuclear medicine department who has which has a very active oncology surgical unit are using intraoperative gamma probes. Now we come with a very basic instrument which every nuclear medicine department has, is a gamma camera. The gamma camera was designed or discovered by Anshu in 1957. This is the basic prototype Anshu's gamma camera. This is a very simple gamma camera 1980s, where it has only the detector assembly, and there is a stand where the detector can move up and down. That's all. There is only one way of movement, and this is a trolley on which patient used to lie, and that trolley used to bring under the camera, and a simple planar imaging used to be done. In the early 80s, we used to have this type of camera. Then came the dual head detectors cameras, which has the capability of rotating around the patient. So in 90s, we had started having SPECT cameras. Initially, we used to use gamma cameras in 80s. Now you can see how this diagram reflects the prototype of Anshu gamma camera. Here is a sodium iodide crystal. These are the collimators used. The collimator used at the face of the crystal, of the sodium iodide crystal. These are the photomultiplier tube, and this is the electronic circuitry. The same, this whole head of the gamma camera is being represented in this picture. Now, as far as the gamma camera types are concerned, there could be a small field of view gamma camera. The small field of view, you can see very small field of view, where it is 10 into 10 centimeter is the total field of view. Where the large field of view gamma camera, you can see very large detectors, large head, which can be 50 into 40 centimeter, and maybe largest is around 80 centimeters. And the crystal size can vary depending upon the use. 5 by 8 inches, 3 by 8 inches, half inches, or 1 inch thickness. Usually the 3 by 8 inches or 5 by 8 inches sodium iodide crystals are used. The photomultiplier tubes behind the crystals can be as small to 70, and in some instances 122 if there is a large field of view gamma camera. So gamma cameras can be small field of view and a large field of view. This is a special gamma camera, which is a small field of view with the pinhole collimators used for imaging the small organs like thyroid. Like we image the ultrasound, and then we can see if there is a nodule on ultrasound, whether it is a cold nodule or hot nodule. This pinhole collimator is used with small field of view gamma cameras. They are less often used, but few departments still, they have very small field of view planar gamma cameras. Now, this is the spectrum of gamma camera designs, which with time, how the gamma cameras had changed in design. It was initially single head camera, as I shown you, that has a capability of rotating around the patient. There was a gantry, the detector was rotating around the gantry. Then it came dual head detectors. These detectors were either fixed angle or variable angle, means you can have some angle between these two detectors, or they were just 180 degree opposite to each other. Then we had multiple crystal camera like triple head cameras, and there are ring like design, like multiple crystals around the patient in fixed geometry, and these are commonly used for the brain SPECT. You can see the patient head only can be accommodated. They are very less often used nowadays. Now you can see the single head with the gantry, which can be rotated around. This is a different type which can be rotated, dual head, and this is triple head cameras. What is the advantage of having multiple crystal in the camera? Adding the number of crystal to camera increases the sensitivity without compromise in the resolution. So you have more heads, your sensitivity of the camera increases. There's a faster acquisition. If you have a dual head camera, you can take anterior image and posterior image of a patient simultaneously. You can take both the lateral images simultaneously. So this is faster acquisition time. You saves the time. When you are saving the time, very sick patient, it becomes very comfortable. Within few minutes, you finish a scan, which would have taken half an hour to 40 minutes. So more the crystal gives faster acquisition, increasing the sensitivity without compromising the resolution, And when the time is saved, you can really increase the throughput of a busy nuclear medicine department. Nowadays, the dual head variable angle cameras are basically the workhorse of a nuclear medicine department. Majority of nuclear medicine departments have dual detectors, gamma cameras. Now, as we know, these, if the cameras are planar cameras were used initially. The planar camera will give you pictures in only anterior, posterior, lateral view. It was the planar image. It was not giving you information of depth. It was only two-dimensional image. Then came the SPECT cameras. SPECT cameras, single photon emission computerized tomography, means these cameras has the capability of rotating around the patient, either in a continuous mode or in a move and stop mode, where with each stop, with each angle, the camera detector stops, gathers the radiation events coming from the patient, and then moves to another angle. Another takes another angle. It takes another events for a few seconds, then move another angle. So around the 360 degree of the patient, it acquires the data in different angulation and make tomographic images. You can see this very simple picture. Here it is a single head gamma camera. This is a single patient is lying down. How the patient is moving 360, detector is moving 360 degree from anterior to the lateral, coming posterior, and then right lateral, and then again coming anterior. Same way, dual detector, it saves the time because the both detectors, one detector A moving from anterior projection to the posterior, and the posterior detector is coming laterally and coming anteriorly. So time is halved. Same way, the time is reduced to 1/3 if we have 3 detectors, and each detector is moving around 60 degree to complete the 360 acquisition. Here, 2 detectors, each detector is moving 180 degree to acquire the data. And when there are multiple crystal in a ring form around the patient in a arranged array form, then whole data is being simultaneously acquired, and you can complete the tomographic images. So these are various type of SPECT acquisition. You can see here in cine loop how the dual detectors are moving around the patient, and the radiation is emitting from the patient, and detectors are moving continuously, gathering the data around the patient on a particular organ of interest. Like in this patient, the angle is 90 degree, where the 2 detectors are acquiring the data around the heart and getting the myocardial perfusion SPECT study. So depending upon which organ, you can have specific angle, and this is 180 degree acquisition, and this is 90 degree acquisition, gamma dual detectors angulation and SPECT study is going on. Now, as the detector was moving around the patient, there are some gamma cameras models which can be moved from the gamma camera to coronary or intensive care unit, where the patient is so sick, cannot be shifted to nuclear medicine department. So there are very few hospitals. They started in early 80s, but nowadays, because of complexities and their maintenance on technical ground, because they are moving sometime, they may have some maintenance problem. So they are less often used, but they are very useful for intensive care unit patients. You inject patient the myocardial perfusion scan, the thallium or systemib or tetraphosphamide when the patient had chest pain. And when patient gets stabilized, move the camera in the ICU, take the planar images and see whether the patient has a defect. And if there is a defect, it means patient had a sustained myocardial infarction or angina, because there is a defect which corresponding to the at the time of chest pain. So these are the few types of gamma cameras which are being used. This is another gamma camera, which is in a ring form. You can see the detectors are all around, which we have seen in RSNA, which is very less oftenly used, but it is very good for the brain SPECT study, where you are doing the tomographic images of the brain. You can see this gamma camera, and these are the arrays of the crystal which are arranged around the patient in 360 format, and the patient head is positioned inside, and the data is acquired from all the angles simultaneously. These are multiple crystal ring design gamma cameras, which are very, very less often because their use is only limited to a particular organ like brain. Now, these were the gamma camera design. Now it comes in gamma camera that the detector design, detector technology. We conventionally gamma cameras, we have a sodium iodide crystal, which are very, very heavy. And they have a advantage of that you can have larger field of view gamma camera, like 50 to 40 centimeter, depth is 40 centimeter, but they're very heavy. Each crystal is around 150 kg. So gamma camera is also very heavy, from 1 quintal to 2 quintals. Whereas this current generation gamma cameras which are coming, which are very costly, which have a detector systems which are very, very small, in the size of 20 to 20 centimeters, very, very small detectors. And they have very small crystals of the size of few millimeter, maybe 3 to 4 millimeter size, pixel size detectors. They are very small detectors. They are lighter, portable, faster acquisition, high resolution. And both for energy resolution is very high, and they are very light, 25 kg total detector weight, and total gamma camera becomes 135. And this solid state detector, so semiconductor detector, is made of cadmium zinc telluride. It is a very costly, but it gives very faster image acquisition, sharp image, good energy resolution, and they are frequently used for specific organ imaging like breast or cardiac SPECT. You can see this is the breast gamma camera, very small scintillammography is being done. It is used in this gamma camera crystal is used a solid state detector like CJD crystal, which I have described. This is another type of camera, the D-SPECT, where this is the detector system, fixed angle, where the detector is solid state, which is stationary, has multiple pinhole collimators, and it is just focused. Patient is nicely sitting on the chair, and this detector system is focused over the heart, over the chest of the patient, and the image finishes within 3 minutes, because very high resolution, faster acquisition, high sensitivity crystals, which gives you very crisp images within 3 minutes. This is a new technology, and it is many hospitals now acquiring if they have a high cardiac SPECT volume. So they are going for these systems. Now we comes to another technology, which is called hybrid technology, SPECT-CT. Now, if you see in this image, you see conventional gamma camera. This is a conventional gamma camera gantry. And these are the two detectors, anterior detector and posterior detector. And the posterior part of this system has a dedicated CT scan. You can see this pictogram here. This is a CT scan. And this is the gantry of a gamma camera, which is placed on in tandem on a single platform. And this is the bed, which moves within the gantry. And you can acquire the SPECT data and CT data. SPECT data is acquired in conventional manner, because these are conventional sodium iodide crystals, very large detectors, and then you take tomographic images and then CT, and they get fused together. And this is called SPECT-CT, which is many hospitals now are acquiring, gives you both information of function as well as morphology. Here come another type of CT scan. This is the conventional image. And this is the solid state detector SPECT camera, which you can see. This is C-shaped detector, very placed here, and this is the CT, diagnostic CT, solid state detectors. Gives you advantage, which I have told before, faster acquisition, very good high resolution image, high sensitivity image, along with the CT, very good images. Now this image acquired on the SPECT-CT, the myocardial perfusion SPECT image, you can acquire the SPECT data as well as the CT coronary angio data in the single machine. And you can see there is a circumflex artery, the RC artery showing a block, the same area is showing perfusion defect. So you can have both the morphological coronary artery information on the CT data. You can acquire the CT coronary angiography as well as myocardial perfusion SPECT scan on the hybrid SPECT-CT scanner. Now comes to very commonly used, our workforce of nuclear medicine department, which is now at many departments, the PET studies are done more than the gamma camera studies. That this has become a paradigm shift in nuclear medicine departments. Now the PET-CT scanner has revolutionized the oncology imaging and cardiac and brain. You can see this is also like a hybrid imaging here. A CT, diagnostic CT scan and diagnostic PET scan is being placed in series in a tandem, and the data is acquired first CT and then PET. You can see here acquisition. This is the sketch of a PET CT. The first patient moves into the CT gantry, you acquire a CT data, and then moves into the PET gantry, you acquire the PET data. Now this CT data is used for both attenuation correction as well as for the anatomical information. So the PET data is being, the attenuation correction is done with the CT information, CT morphological map of the that particular patient, and this data is attenuated, corrected, and this is the attenuated corrected PET image, and this is the fused image. So this is commonly used in clinical practice in oncology. This is the most common PET CT, conventional PET CT, which is present in various departments. Now you can see that PET crystals are very small, arranged in an array form and ring form around the patient. The multiple rings, and there all crystals are arranged in the ring and array form. This is the conventional PET detectors. Now this is routinely performed. This is a PET CT scanner commercially used in various departments. You can have various companies which are giving all these PET CT scanners. Now the recent advances in PET CT scanner for last 1.5 years to 2 years is the total body PET CT scanner, which is named as new Explorer. This has a long field of access. So you complete whole PET CT scan of entire patient within less than 1 minute or 1 minute. It has a LSO crystal. You can see here LSO crystal, the long axial field of view. You can see the long axial field of view. And here the silicon photomultiplier tubes are used, and the time of acquisition of whole body, 165 to 170 centimeter length of the patient is covered in less than 1 minute or around 1 minute. It has a high resolution of 3 minutes, high sensitivity. The only problem is the cost. Wherever this current generation, the PET CT, the axial field view varies from 60 to 30 centimeters. So you acquire the data in various bed positions. First you take head, or then thorax, then abdomen, and then pelvis, and then the mid thigh. So the data is acquired in bed position from 4 to 5 or 6 bed positions are taken, where in the single bed position in the total body Explorer, the whole patient is completed within 1 minute. So those patients which are very sick, cannot lie for longer, these cameras are useful. Number two, you can do dynamic studies after injecting the isotopes, just like a DTP scan, how there is a peak of isotope in that particular organ, how it is decaying or coming out of the body. So you can do dynamic data study. It has a very high resolution and very sharp, because each crystal is around 2.9 to 3 millimeter. So high resolution images on total body PET scanner, but they are very costly. But initial clinical trials on these scanners have been found to be very, very encouraging. Now comes another, the scanner, which is the PET MRI scanners. The few departments of nuclear medicine have also acquired the PET MRI scanner. In India, currently, there are 4 PET MRI scanners, and there are 2 or 3 under installation. So these PET MRI scanners gives you an advantage of both MRI and the PET study, which are done simultaneously. It is a simultaneous acquisition of PET MR data. You can see in the cross-section image here. This is the PET MRI gantry, where there's a radio frequency body coil. This is the PET detectors, then again the gradient coil, and this is the magnet. So all this interposition together. Now, the photomultiplier tubes were very difficult to function in the high magnetic field. So special photomultiplier tubes, which are called avalanche photodiodes, APD, or nowadays, which is current generation PET MRI using a silicon photomultiplier, SIPM, are being used, which work in high magnetic field, and there is no problem for data acquisition for PET. So you have a LSO crystal here. There is a the array of crystals of LSO, lutetium silioxylate crystals, which are better and they have a high time of flight data. These crystals are arranged, then you have a silicon multiplier tube. So they are arranged, and they gives you high sensitivity and advantage of both PET and MR. Both are molecular imaging agents, gives you high quantitative image data. Especially they are going to give revolution in gynec oncology patient like CA cervix, and in the brain PET like dementias and the epilepsy focus localization. So they have a great potential in neurology and oncology indications. Probably this is the last slide where I can see the PET MRI, the blended modality could be the choice of future. Thank you very much for giving me opportunity. These are the spectrum of nuclear medicine instruments which are present in current generation nuclear medicine department. Thank you so much for patient hearing. Over to you. Dr. Arun, over to you.
Thank you so much, sir, for such a wonderful talk. Now I think we have with us Dr. Sebastian Kirk ji. I think he has some issue with time, so he wants to complete it first. So is it okay, Dr. Anshu? You can please unshare your.
Dr. Mr. Rajni, hello.
Ji.
As
Yeah,
I
yes,
informed
sir,
that
yes.
I'm having an audit, so I need to go.
Okay.
So please take my talk first, please.
Okay.
Please. Yeah.
Okay,
because I already
Dr.
informed
Kheruka
my
ji,
talk
we are really sorry we cannot change the order now, as Dr. Pankaj also have some urgent work. So somehow we are running out of time. Actually, we already are in late, so I don't want to go further for much elaborate introduction. So I will just introduce Dr. Pankaj Tandon. He is one of the senior scientists in AERB. He's working us for many long years, and he's here in nuclear medicine. So he do not require any sort of formal introduction from me. So now I hand over directly to Dr. Pankaj Tandon for his talk. Sir.
Thank you, Dr. Rajni. Thank you, Dr. Rajni, for such a wonderful introduction. And I'm really thankful to AFOMP, especially Dr. Chogle, who has given us an opportunity to present this particular four talks on this particular school. Hope I'm audible and it's clear. Shall I share the screen, ma'am?
Yes, you are audible and everything is clear, sir. Please.
Thank you. I just see to it. Yeah, thank you. Yeah. Could you please stop sharing your screen? My screen is visible?
Sir, please go ahead. Sir.
Thank you. Thank you very much. Thanks a lot. First of all, I'm really thankful again to Dr. Chogle, and that the talk which I'm going to give on this platform is unusual incidents in nuclear medicine and its reporting mechanism. As we all know, that when we are working in the field of nuclear medicine, it is likely that we are going to get any kind of incidents while working with this practice. And those are called unusual incidents. And I'm going to cover up what are these incidents and how the reporting mechanism we have in our country. First and foremost thing, we should understand what is incidence. Before getting incidents, we should know the definition of event, which we Google it tells about that any occurrence that requires a report to the regulator or to the operator or a communication to the public is called event. Now, event is defined into two broad category. One is called incident and other is called accident. And why this terminology have incident and accidents have come, if you see the International Nuclear Event Scale, the events has been divided into 7 categories: level 4 and above and level 3 and below. What is incidents out of the event definition what I just informed? It is used to describe the event that are less severe than accidents. So it clearly tells about anything which is less severe than accident, but it is an event, is called incident. For communicating the significance of events to the public, INES, that is International Nuclear Event Scale, which is generally being used for nuclear kind of accidents or events, They have rates into one of the 7 categories, and up to 3 it is called incident. And when this incident or event become fatal, uh, or we can say it is significant consequences takes place to the people, to the environment of facility, then definitely it leads to a higher hazard potential, and we call as an accident. So if you see the scale which has been shown over here, that from up to 3 level is called
Yes,
incident,
sir.
and from 4 and above
You-
is
Your,
called accident.
your slide is not visible right now.
The slide is not visible.
Yeah, your slide is not visible. Please share your slide.
It is visible. I understand. Maybe something maybe there in your case.
Not it. I haven't seen any slides.
Miss Rajni, my slides are visible.
Yes, for all. We cannot see your slides.
Okay. My slides are not visible, Dr. Rajni.
No, sir, your slide is not visible. Even
Not visible, not visible.
Not visible,
Okay,
sir.
Yes.
okay. I will share it again. I will share the
Yeah,
screen
please.
again. Yeah, just a minute. Is it visible now?
Not yet, sir. We cannot see your PPT slides yet.
Okay, just a minute.
Not yet, sir.
Just a minute.
Window, and then we can see your monitor, I guess. Minimize
Just a
this
minute.
window. Yes.
Yeah.
Minimize this Google one also. Yep. Now you can.
Now it is fine.
Yeah. Please go for
Okay,
this
sir.
slideshow mode, and now we are good to go. Yes.
No, as I think this is visible now. I should start
Yeah.
continuing from this slide.
It's visible.
Okay.
It's visible now. We can start. Yes.
Okay, thank you. So as I was informing that the event has to be decided into 2 parts. One is called incident and accidents, and this is called 0 to 3. It is incident, and when we talk about 4 to 7, it is called accident, as per the INS user manual, which has been published by IAEA in 2008 edition. Now, why incident occurs, that we should know. First and foremost thing, what happens and why this incident occurs. The important thing is inadequate communications, maybe training, inadequate awareness of the workers towards radiation safety, or workers are not informed of the presence or location of the radiation source or radiation generating equipment, or they are unaware that a source is being maintained at that location. So any one of these causes may lead to some kind of incidents. Now question asks or question arises that why incidents to be reported? Even if the incident takes place, why we should report the incidents? See, hazard, causes and contributing circumstances are lost if not reported. Suppose incident has taken place and if we don't report the hazard or causes, why it has happened, it lost. So it makes us very important to report this incident. The fact that many incidents come within inches of being disabling injury accidents, making failing to report them all the more serious. If you don't report, then it may lead to some kind of fatalities, or may go to the accident mode when we define the event. When incidents are not reported, their causes usually go uncorrected. That means they may happen again, perhaps producing tomorrow's disabling injury or fatality. So it is must, we should report the incident. Why the incident is not reported, though it should be reported if the incident takes place. The most common failure is to understand the importance of reporting and the harm that could result by not doing so. If the incident has taken place in your department, then generally we don't understand that if we don't report, what will happen. So until and unless then we know the common failure, until unless we don't know what is the understanding is proper, we will not report the incident. And that is the main reason the incidents is not reported. It may happen that many employees do not want to report an incident because of the following reasons. Either maybe fear of management disapproval, or not wanting the incident on their work records, dislike for the red tape involved, not wanting to lose time from job assignment, reluctance to spoil the department's safety record, not wanting to be the subject of incident investigations. So definitely incidents are happening, but because one of the any causes which I just told, there is a failure or the incidents are not reported. What can be learned from an incident if the incident takes place? The whole purpose of reporting and investigating a near miss incident is to find ways of making sure the same element that were present on that occasion do not result in an accident at some future time. The answer should suggest ways to prevent recurrence. Perhaps there is a need to develop new rules or procedures, or maybe more thorough training is required. In any case, the reporting of the incident is the first and foremost vital step that needs to be taken, and keeping in mind that it will lead to accident in the future. So here are certain questions to which answer must be sought. What were the circumstances surrounding the near miss? Why this incident has taken place? Was there a hazard that employees should have been aware of? Is there a safety rule covering the situation? If so, did the almost victim know it? If there is not such a rule, should there be one? Were any safety devices, clothing, or equipment used improperly or not used at all when they were called for? Have there been other near misses at the same time? The foremost and important thing, we should find out the root cause analysis of any incident which has taken place to prevent the recurrences in the future and not allowing to become an accident. So stop, think, and act. Is your workplace as safe as it could be? How well prepared is the organization to prevent and manage incidents? Such questions should always be fully and honestly answered by the radiation safety officer or radiation protection officer who takes care of radiation safety in your organization, and should always be matter for critical examination, especially in facilities where the activity of radioactive source involved is high. An incident management reporting system helps you answer these questions and ensure that your organization is always prepared to prevent and manage near misses, incidents, and accidents. Incident reporting is a requirement of any occupational health and safety management system, and when this is not done efficiently, the flow-on effect may result in excessive cost to the business besides the human exposure. Importance of reporting. Why incidents reporting? I'm keep on insisting, whatever mechanism is there in your country, in your organization, please do report the incident. Employees should be encouraged to complete incident reports if something happens, as the process information can benefit everyone. Below are few reasons which tells that reporting incident is important. Reporting enables the correction of the situations and helps to prevent similar future occurrences. Reporting allows employers to trend incidents and proactively identify potentially hazard conditions, keeping the workers safe. Incident reporting can act as a heads up to management that helps identify potential problem areas that needs to be fixed. Prompt reporting provides management with a historic record of the facts when the incident occurs. As time passes, facts become clouded and recollection of details fades. Key evidence during the time of incident needs to be documented right away, allowing for a plan of actions to be enacted immediately that will help all parties to manage the situations. By quickly reporting incident, time loss can be avoided, light duty can be provided right away, allowing the exposed employer return to work in a capacity that meets the restriction. And I understand that after seeing this slide, have the habit of importance of reporting the incident. Now question arises, when should I report an incident? It is extremely important to report incident right away, no matter how minor it may be. Even if the exposure is minor or if there is no exposure and if you feel it is not worth reporting, incident must be documented. Whom should I report? When the incident occurs, you should report immediately to your supervisor. Do not fear reporting. It is a necessary aspect of creating a safer work practice, play for safe workplace, and you are protected by the law. Lack of commitment to holistic safety. Many incidents resulted from organization or business not adopting a holistic or systemic view of safety. For example, incidents have occurred even when organization is focused on procedures, interlocks, and barriers. While these are important areas to consider in the management of safety, it is equally important to consider human and organization factors. For example, many of the incidents may not have occurred had the organization provided trainings to staff on how the interlock worked and provided safer system of work. Example, using a checkbox. Easier system protocols that handwritten notes should be provided that how to see to it, how this interlock works, because interlocks and other administrative mechanisms are there, but the note training is provided how to act on if certain incident has taken place. The lesson to be learned from the incident is that in addition to addressing technological issues, safety management needs to consider human and organizational factor and develop a safety culture in the organization, learn more about the holistic safety. There are incident reporting agencies that are there. We talk about Australia or UK or USA, France, Russia. Every country's regulatory authority is having an incident reporting agency, and the same we have in our country that is called Atomic Energy Regulatory Board. What are the unusual incidents happen in nuclear medicine? As you all know, misadministration, wrong radiopharmaceutical, wrong patient, lactating patient, pregnant patient, wrong route, wrong acting, spillage of radioactive, personal contamination, death of patient with high activity. These are all termed as unusual incidents in nuclear medicine. Misadministration countermeasures immediately use all available means to minimize any adverse effects such as expeditious removal of orally administered radiopharmaceutical by MSS, gastric lavage, laxatives, or enemas. Accelerated excretion of intravenously administered radiopharmaceutical by hydration, diuresis, etc. Removal of urine by catheterization from patient who cannot void spontaneously, and when appropriate, use of blocking agents to diminish the absorbed dose to the thyroid gland, salivary gland, and stomach. Misadministration consequences, not justified exposure, it increased the radiation risk, it delayed the diagnosis, it increased the cost, increased the workload, reduced confidence. Radiation safety implication in handling incidents in nuclear medicine. Patient safety is one of the most important things. Then personal safety, then worker safety, then environment safety. All safety has to be taken into account, and this method has to be followed. Estimation is generally done by radiation safety officer, radiation protection officer, whatever name you have, or a radiation safety officer or a person who is taking of radiation safety in your organization. Management of radioactive contamination, when we talk, suppose contamination has taken place. Persons suspected of being significantly contaminated should be removed from the area of contamination. In the event of major spill involving iodine radioisotope, the use of thyroid blocking agent, for example, potassium iodide, should be considered. Take particular care in case of yttrium-90 colloid or particulate to avoid spread to wounds, eyes, nostrils, or mouth. Personal decontamination should be undertaken according to the area of the body and as follows. Eyes should be irrigated with saline solution, 0.9% sodium chloride solution, or be distilled or main water. Hands should be washed with tepid water, mild soap or hand wash solution. And during the period of COVID in last 2 years, we have learned how to wash hands frequently with 20 seconds protocol. Now, if we continue it, contaminated fingernails may be scrubbed lightly with a soft nail brush for contamination that is difficult to remove. Disposable rubber gloves may be worn for several hours to promote perspiration of the hands, which may assist in removal of contamination while preventing its spread to other surfaces. Skins other than that of hands should be swept gently with a cotton wool pad soaked in a mild soap and hand wash solution, preferably neutral pH. The solution should have and rinsed well. Do not vigorously scrub the skin using detergent, as this may affect the natural skin barrier and increase the risk of internal contamination. Contamination wounds should be washed under fast running tap. If the wound or the face, care should be taken not to contaminate the eyes, mouth, or nostrils. Finally, the wound should be washed with water and gentle antiseptic and water from dressing applied, and attempts to remove all contamination from the skin may not be feasible or desirable. Some radioactivity may be trapped in the outermost layer and will remain until normal flowering of 12 to 15 days. Personal decontamination should be continued until monitoring shows that less than 10% residual contamination is removed at each cycle, unless there is a risk of contamination entering the bloodstream through the roughing or breaking of the skin. If the contamination is due to iodine radioisotope, the affected area should not be treated with any material that contains oxidizing agent or acids, as this can result in the production of volatile molecular radioiodine and risk of inhalation. The use of acid or metal surface may also cause unnecessary corrosion and result in a greater difficulty in future decontamination procedures. If the measurement of residual contamination indicates that the level of radioactive contamination remains greater than the permissible limit, the item should be stored to allow the radioactivity to decay, and also action should be taken to prevent the accidental return of the item into stock or other use. Now, death of the patient is one of the incident which you cannot avoid because it can take place in a high dose therapy ward where high dose iodine is already been administered, and after the same the patient died, collapsed because of the reasons unknown during that time. A nuclear medicine physician concerned should ensure, after consultation with the nuclear medicine physicist or technologist, that the exposure to radiation of any person handling the body is minimized at the time of death. The body should be clearly labeled with the radionuclide form and what is the estimated residual activity. The body should be handled as little as possible using strict procedures for prevention of contamination with body fluids. If the patient dies shortly after undergoing a diagnostic nuclear medicine procedure, no special precautions are required because we all know in case of diagnostic nuclear medicine, the activity administered is very, very minimal in the range of 3 to 5 millicurie. If an autopsy is required, in such cases, consideration should be given as to whether a CT examination would be sufficient to or not. If a corpse contain activity in excess of the limit prescribed by the regulatory authority of your country or in our country, autopsy cannot be postponed for a suitable period for radioactive decay. The doctor performing the autopsy should be informed of the radiation levels likely to be encountered and of the hazards involved, the methods employed, and the precautions adopted. But usually, autopsies is always discouraged. If it is known the radioactive material used for treatment will have been selectively absorbed in a particular organ, example, iodine 130 in the thyroid, the organ should be excised and removed from the work area before the autopsy examination proceeds. It may be later be disposed of with the body. If it is known that radioactive material will be distributed in a particular body fluids like iodine-130 strontium in the bladder, they should be drained off using suitable equipment before the examination proceeds. In general, these fluids may be safely disposed of while the sewerage system, but I'm keep on telling that possibly autopsies are generally avoided because it may lead to contaminations at other places until unless it is supervised radiation safety officer and doctor is aware how to handle the cadaver. The equipment should be decontaminated by thorough rinsing in a detergent solution followed by washing or running water. What are the consequences of an accidental contact with radioactive corpse? Depending what the radioactive material is, a dose may arise through ingestion of material on the hands, inhalation of dust, or from exposure to gamma rays. However, the magnitude of dose will not be anywhere near the level that causes radiation sickness. We know NVD syndrome, that is nausea, vomiting, and diarrhea. There will be no immediate effect. It will be probably be not greater than the amount of radiation received over a short period from natural sources of radiation or from the medical X-ray. Under normal circumstances, the highest dose that could be received from the body would not be more than dose from a small number of conventional medical X-rays. However, it is generally accepted that any exposure to radiation entails a degree of risk. The risk in this case is small but not negligible and should be avoided if it is reasonable and practical to do so. There are two documents which were prepared by IAEA, where I was a part of the committee for preparing this document for medical events. But this document is, many countries have not started using it or not. That is use of inner scale for unplanned events affecting patients undergoing medical procedures and additional rating guidance, how to rate this event which has taken place in the medical practice. I'm not talking about Atomic Energy Regulatory Board, our regulatory authority in the country. We have a system how to report through our e-licensing, because this is the country where license, all consents are being issued online. Online system is there. So this is the portal which is called eLORA, e-licensing of radiation application, where if you see, if you go to that particular website, we have a regulatory form which we are talking incident reporting mechanism is there. How to report it already helped me know, it guides about if incident has taken place, incident report you have to submit over there. Once you have to fill what's the date of incident, what type of incident, what then subtype of incident, where the source loss has taken place, person in charge of incidents, contact number, all this detail you can fill it up. And next time you have to update the incident as and when the progress takes place, that what is the update, because it may not be happen once the incident takes place, you have to directly report it, then you can update the report consequently. Then we can incident investigation report that comes after the incident investigation taken place by the organization. So what I want to say, that we have a mechanism well established for reporting in our online, and that not only takes helps the regulatory authority, but that will also help the others in the country that how to avoid such incidents. With this, I am really again thankful for a patient hearing. Thanks to AFOMP, thanks to Dr. Chogle and Dr. Rajni for introduction and giving me an opportunity to talk on this subject. Thank you very much. Over to Dr. Rajni. If any questions are in chat box, I would be happy to answer. Thank you very much.
Thank you so much, sir, for such an elaborative and interesting talk. And we have asked for many questions from the participants, but I think the presentation was so good and it was so easy to understand. The presentation was clearly very nice. So I think the participants do not have any query. So I want to thank you once again. So now we have Dr. Sebastian Kheruka with us. He's one of the renowned medical physicists, medical physicist in nuclear medicine physicist. Right now, he is consultant in medical physics, nuclear medicine in Sultan Qaboos Comprehensive for Cancer Care and Research Center in Muscat, Oman. He is a very famous name in India, as he is one of the pioneer in medical physics. He has been working to various positions in academic positions, maybe like chairman to CNMS at India. He's a deputy national coordinator for distance assisted training for nuclear medicine professionals for IAA. He's been life member to SNMIL, MP, IRP, and he was also an ex-president of Nuclear Medicine Physicists Association of India. So he's a very popular name and very famous among the professionals. So I won't waste much of time in introduction. So I request Dr. Kheruka to please take a lead and have a presentation.
Thank you, ma'am, for
Yeah.
your nice introduction. Just give me time to share my screen.
Yeah, sure, sir. Please go ahead, sir. Yeah, we can see your presentation, sir.
Yeah. It's coming.
Yes.
It's okay, right?
I think, sir, we cannot see your video. Is that what you want? You won't be sharing your video?
No, without audio, without video.
Okay.
It's okay.
Okay, sir.
Slides is visible now. Slides is visible now.
Yeah, slides are visible. Please go ahead, sir.
Yeah, thank you very much for giving a nice introduction and give me an opportunity to talk in the AFOMP 2022. My talk is on the quantitative analysis in nuclear medicine, that how the nuclear medicine help in the quantification and what is the role. So nuclear medicine playing a very important role to diagnose the disease and to know the response of the therapy. And these are the quantitative indices which can be extracted by nuclear medicine. That is count, relative quantification from count ratio, activity concentration, percentage injected activity, functional and metabolical activity volume, that is relative cardiac function, brain metabolism, and standard uptake value. That I will explain one by one. Why the quantification is needed in the nuclear medicine and what is the importance of it. It aids the accuracy of the reporting, that is disease versus no disease, allow the objective analysis of severity of disease and therapy response, help the inexperienced reader by providing additional adjuvant to visual analysis. Quantification can be affected by multiple factors, and understanding of these is crucial in order to avoid misinterpretation. These are the factors which can affect the quantification in the nuclear medicine: patient factor, physical factor, and technical factor. So first I will talk about the what are the things which can be used for the quantification in the nuclear medicine. In planar single photon imaging, the number of photons detected by a scintillation camera as falling inside the defined acceptance energy window at a position corresponding to a pixel in the image termed as a count. And in non-imaging probe, that's like a Sentinel probe, measurement a counter which is attached with a probe, and some of the number of photons which is detected in a time interval. Example are obtained the cumulative activity in the Sentinel nodes and dosimetric studies to obtain the cumulative activity over a time period. The number of counts in a certain area in the image is calculated for a region of interest, that is called region ROI, or volume of interest defined by the user. ROI in a single image counts ratio for several ROI can be used to detect differences in activity uptake. An example is comparison of activity between the left and right kidney. ROI over time for example, dynamic study can be important in addressing the biokinetics of a particular organ or a tissue. Activity. So now I will explain that, activity. What is the activity? Activity is a measure of number of nuclear transformations occurring per unit of time. The unit for activity is the vector defined as one transition per second. The order technique, order unit, which is Curie, still is in the common use. The goal of quantitative nuclear medicine is to determine the absolute activity in a given volume. For example, patient an organ or a tumor of per unit volume, that is spectral parameter, by external measurement of the radiation emitted by a patient. Single calibration factor, that is your CPS per megabecquerel, can be used to convert a number of counts into an activity.
Kheruka ji, Dr. Kheruka.
Yes. Yes.
Hello, sir.
Yes. Yes. Yes.
Somehow we are not able to hear it properly. I think your voice has some problem.
Oh, now you can. My voice is
It is
coming.
audible, but it is not clear.
Oh, I will. Maybe this is the issue of this. Net. I will try. Value. Now it is coming.
It is better. It is better than before.
Yeah. Value regardless of location of the ROI in the image. Activity concentration, that is, this is the activity concentration. The activity in a source in air can be accurately determined from the counts in an ROI that is large enough to completely cover the image of the source. However, when aiming to determine the
There is a lot of
activity
disturbance.
concentration,
Lot of disturbance is coming. Dr. Kheruka, lot of disturbance is coming. You just see because your voice is cracking.
oh,
Just see your connection because such a wonderful presentation will not be good then.
oh, my connection is right. I don't know what is the problem. I will try. Now it is okay.
The voice is coming, but it is cracking actually.
Oh, I will try. Now you just 3D tomography modality generally is required.
I think, sir, you can switch off and switch on your video audio settings once again.
One minute, please.
Yeah, sure, sir. Sure, sir. Please.
Now it is. Should I stop sharing again? I will share, please. Okay.
Sir, somehow your voice is now clear. I think you can start again.
Okay. Now I will share again. Yes, okay. No. Now it's okay.
Yes. The slide
Now
is
it's
not.
okay. Yeah.
Yes, it's fine, sir.
It's not visible.
It's better. Yes, it's better than before, sir. Please go ahead.
Yeah. So yeah, now I will start. Yeah. Thank you. Activity is a measure of the number of transformations occurring per unit of time. The unit of activity is the becquerel, which is defined one transition per second. The older standard, the Curie, is still common use. The goal of quantitative nuclear medicine is to determine the absolute activity in a given volume, that is the patient, an organ, or a tumor per unit volume, that is kilobecquerel per ml, by external measurement of radiation which is emitted by the patient. A single calibration factor, that is CPS kilo per megabecquerel, can be used to convert a number of counts into an activity value regardless of location of the ROI in the image. Now, what is the activity concentration? The activity in a source in air can be accurately determined from an ROI that is large enough to completely cover the image of the source. However, when to determine the activity concentration, that is megabecquerel per ml, a 3D volume tomography modality generally is required. Under certain conditions, activity measurement can be combined with an additional modality to obtain the volume of the source, that is CT, study of the tumor site, to know the tumor site. Percentage activity. Now, activity uptake expressed as a percentage of injected activity in sometime convenient measure. However, it is necessary to measure the residual activities such as syringe and associated tubing after administration and to correct for physical decay. For example, thyroid uptake probe. Nuclear medicine imaging can give information about the functional volume such as ejection fraction in cardiac SPECT, functional volume mostly in cardiac, that is end diastolic and systolic and stroke volume in cardiac imaging, are indirectly estimated through activity measurement, assuming the measured signal intensity is proportional to the blood volume in the left ventricle cavity. In other words, measuring such volume does not involve actual volume delineation. The accuracy of this functional volume estimate is thus directly which is related to the accuracy of activity measurement. In nuclear medicine, imaging also used to give the information about the metabolic activity, for example, in PET or volume with impaired metabolism. Relative cardiac study. In nuclear medicine, sometimes we are using two different modalities to compare the relative function of the organ. For example, you can see this is a technetium MRI scan showing a perfusion defect in the inferior wall of the cardiac, which is not present in case of FDG PET scan. That means it shows that viability still is there in this wall, and this patient can be treated by using the medicine. This is the second example where you can see that occipital lobe in case of dementia with Levy bodies showing a less metabolic activity compared there we expect it not showing perfusion defect. In temporal, there is a in Alzheimer's disease, it is showing a sorry less metabolic activity in the temporal lobe, where in the spec it is not showing. In posterior, showing a posterior cingulate island in case of dementia with Levy bodies in the fact, which is not present in the spec. So, like that, by doing the relative comparison, we can diagnose the disease. Now, the SUV is defined as the ratio of the tumor uptake, that is kilobecquerel per ml, divided by the injected activity normalized by the dilution of volume, and that is called SUV. And SUV is the dimensionless quantity. It allows to assess the uptake in a ROI irrespective of the administered activity and the patient weight. The use of SUV as a measurement of relative tissues organ uptake facility comparison between patient and has been suggested as a bias for diagnosis. However, the practice of using SUV threshold for diagnosis is not widely accepted. First is that accurate staging and diagnostic information do not have to depend upon the accurate image quantification, since the relative image content, that is image appearance, is often sufficient for such purpose. Second, measured SUV have a large degree of variability due to the physical and biological source of error, as well as inconsistent and non-optimized image acquisition, processing, and analysis. There are three types of SUV, that is FSUV mean, FSUV max, and SUV peaks. So these can be calculated by using this different formula. We are using normally lean body mass instead of body weight, because of in lean body mass, the adipose tissue is not included. So how the HUE is playing a very important role to diagnose the disease. This is a CA breast patient who came in our department with the complaint of headache for the follow-up. So we performed the scan and we found a lesion in the brain, and simultaneously we found one more lesion in the lung. So you see how this which was unknown that this patient is having this lesion in the lungs also. So like that, this SUV is playing a very important role to diagnose the disease. Then this is the example where we will see that how the SUV we can use to know the response of therapy. Tracer imaging to predict the absorbed dose during therapy treatment plan. Post-therapy imaging we are using to monitoring the radiation dose during therapy to establish correlation between dose response and toxicity. The SUV estimation of individual lesion help determine total tumor tracer concentration and clearance, enabling the assessment of total tumor. This is the example where we administered lutetium-177 dotatate to treat the tumor in the liver region, and then we determine the SUV at different time interval, and we see that after 48 and 72 hours the SUV becomes stable. It shows that the lutetium dotatate remains in the tumor and delivering the dose there. This is the second example where you can see that pre-MIBG therapy imaging, pre-MIBG therapy, it's showing a SUV values in the lesion is high, and after after MIBG therapy, you can see here the
Hello, sir. Have we lost you? Hello. Hello. Dr. Kheruka, are you there? Dr. Kheruka, are you there?
Am I visible? Am I audible?
Please start sharing your. Please start sharing your file, sir.
I'm here.
Yeah.
Okay. So now, should I go before this, or can I start from here only?
From here
Hello?
only. You can start from here only, sir. No problem.
Hello.
Sir, you
Am
can
I
start
audible?
from here only. Yes. You are audible.
From here, I should start from here.
Yeah. From here, I guess. Sir.
Hello.
Yes, sir. You can start with this
Hello?
quantification of absolute activity for therapy applications. Inspect.
Yeah. So therapy application. So this SUV also playing a very important role to see the response of the therapy. That is pre-treatment tracer imaging to predict the absorbed dose during the therapy, and post-therapy imaging to monitoring the radiation dose during the therapy to establish the correlation between the dose, response, and toxicity. The SUV estimation of individual lesion helps to determine the total tumor tracer concentration and clearance, enabling assessment of total tumor dose. This is the example where we have given a lutetium-177 dotatate to treat the tumor in the liver and measure the SUV values at different time intervals, that is 2 hours, 24, 48, and 72 hours. And we saw that there is no change in the SUV at 48 and 72 hours. It shows that the medicine remains in the tumor and delivering the dose to the tumor. Is the second example.
Hello? Hello? Dr. Kheruka? Are you there?
Lost
Hello?
again.
Yeah, I guess we lost him. Okay, somehow we can wait for a minute. Then, of course, if he's not there, we can go to next speaker, I guess.
Okay.
Hello? Dr. Kheruka, are you there? Hello, Dr. Kheruka. Is Mr. Ashish Kumar Jha is there? Jha Sahab is there? Hello?
Yes, I'm here. But Dr. Kheruka is logging in again.
Okay. So Ashish sir, what we'll do? Ashish sir, what we'll do? I think we have lost him somehow, but we have to continue the program.
Actually,
So what we can do is we can start with your presentation. In case he comes, he can finish it off at the last.
Dr. Rajnish, actually, I informed him, and
Okay.
he's logging in again.
Achha, he's logging. Okay, we can wait
Yeah.
for 1 or 2 minutes more.
Okay.
If it in case he's able to come, then we can start with that. Otherwise, we'll start with your presentation. Is that okay, sir?
Ashish, you can make a presentation. Once he logs into it, then we can have the presentation further.
I think Dr. Kheruka has joined. Now let's wait for 1 more minute if he'll come. Yeah, I think he's there. Yes, sir. We can see your screen. Please go ahead. हेलो खेरुका सर, आपकी आवाज नहीं सुन पा रहे हैं. We are not able to hear you properly.
So these are the different factors which can affect your SUV values. For example, this technical factor, biological factor, and the physical factor. So I will explain one by one. This is that how the SUV value is affected by the FOV. The effect of FOV change on standardized uptake values. SUV measurement of lesion in 60-year-old man with metastatic melanoma. Initial image reconstructed with 50 centimeter FOV and 70 centimeter FOV, that is in the B, to include area of primary disease in left forearm. Different FOV with same image matrix size will change the placement of image matrix voxel relative to lesion in images. This can substantially affect SUV measurement of lesion. 70 centimeter FOV SUV value is 4.7, where is 50 cm showing a 3.9. Sometimes the speed also affect your SUV values. You can see here when the speed is 360 seconds per bed position, the SUV value is 6. When the speed becomes 150 seconds per bed position, then SUV value is 5. So reliability of measurement depends on two factors, that is accuracy and precision. Often good precision is as or more important than the good absolute accuracy. These are the different challenges which can affect your quantification in the nuclear medicine. This is the natural background. Now, patient in neighboring rooms or consider and residual activity can result in background radiation. Low count study degrade the quantitative information, needs radioactivity compensation before or after imaging the patient or both. If background is high, need cleaning, additional shielding, background image or count subtract from the patient information. If your background is equal to the gross counts, then it becomes not significant. When gross count is more than background, then it becomes significant. Radioactivity, by definition, radionuclide undergo the radioactive decay in resulting in reduced activity as a function of time. For quantitative tasks, it is important to account for this effect. For example, to calculate the percentage of injected activity in an organ, one need to decay correct and measure activity in organ relative to the time of injection and the injected activity from the time the syringe was measured in the dose calibrator. Similarly, for dynamic study, it is often desirable to remove the effect of physical decay by decay compensating back to the injection time. Decay compensation can be accomplished by scaling the image of data by a factor given by decay factor, and that is your DF, where lambda is the decay constant for the radionuclide and T is the time difference between the time for which the counts are decay corrected to and time of the measurement. Noise results from the radiation nature of radioactive decay process. Each atom of radionuclide has the same probability of decay, which is independent of time, and probability of decay for each atom is independent of other atom. And lower fraction noise can be obtained by increasing the number of counts or by increasing the longer counting time. Radionuclide decay error significantly influence the image visual quality. Relative random error decrease as count per pixel. You can see the N total increase and per pixel counts will also increase, and it will reduce the random error in the image. Increased ability to visualize the anatomical structure and tumor allows the visual effect of random error as a result of the measured quantity. You can see here, when we increase the number of counts, the image quality becomes better than the less counts. Noise is the second example. When we increase the acquisition time, image quality becomes better than the less acquisition time. This is the second example we have. We can show that by using the smoothing filter, you can reduce the noise in the image, but at the cost of the SUV value. The SUV values becomes less when you smooth the image more. So you smooth a image in such a way that resolution and smoothness can be compromised. Peak shifting also affect your image. You can see here, when we shifted the peak, this is the image when when there is a shift in the peak, and this is the peak image where when the image acquired in the window at 140 kV, and you can see here when we acquire the image in 120 kV, then your ejection fraction is 64. When compared to 140 kV image, there the ejection fraction is 73%, 9% is different. Attenuation and scatter also affect your image quality. Primary attenuation is a loss of counts, which is due to the deflection by Compton scatter from detectable path. Scatter is addition of unwanted count due to the deflection into the detectable path by Compton scattering. This is the example. This is the attenuation factor in the spec. It is 5 times to 20 times. In fact, it is 15 times to 60 times. And the scatter fraction in fact is 35%. In fact, 2D 15%, and in fact, 3D is 40%. So you can see here, this is the image which is reconstructed by you and without attenuation correction, showing a hot lungs and flare in the image, which is disappeared after applying the attenuation correction, and the nose in the axilla is visualizing better, and it is showing there is something which is there is nothing in the media sternum. This is the second example where you can see that non-attenuation corrected reconstructed image showing a perfusion defect in the inferior wall of a cardiac, which is disappeared after applying the attenuation correction in the reconstructed image. Scatter, you can see here, because of the limited energy resolution, the scintillation scintillator used in the imaging device, a relatively large energy window is needed to maintain the good quantum statistics. Some photons that are scattered in some small angle in the patient will therefore have a chance to be detected within the energy window. This detection will lead to potential difficulty in quantifying activity and poor contrast, since these photons carry incorrect information about the point of emission of the photons. The scatter contribution depends on the several factors such as photon energy, source distribution, and tissue composition. In addition to the camera-specific parameter such as energy resolution and window setting. You can see here without the scatter, when the energy resolution also affect your image quality. You can see here when the energy resolution was 20%, image 20% when the image showing a noise in the image, compared to the 15%, 11.5% energy resolution. This is the second example where you can see the after applying the scatter correction, the image resolution becomes good compared to without attenuation correction. This is the third example where you can see after applying the attenuation correction, the contrast resolution increase in case of PET image. Random correction also affect your image quality. You can see this is the image without random correction showing a noise in the image which is disappeared after applying the random correction. Random correction can be applied by using the delayed coincidence window. The motion also affect your image quality, which can be seen here. There are two types of motion, voluntary motion and involuntary motion. This is the example. Voluntary motion can be minimized by using the short acquisition time, instructing the patient to remain as still as possible, positioning the patient to maximize comfort, and using straps, pillow, or other constant to restrict the motion. This is the example where you can see after applying the motion correction, the image quality becomes good compared to without motion correction. This is the involuntary motion. The involuntary motion is due to the respiration, respiration and the cardiac motion. And these involuntary motion can be rectified by using the respiratory gating and the cardiac gating. This is the example where you can see that after applying the cardiac gating or respiratory gating, the SU values is increased. This resolution and partial volume also affect your image quality. Spatial resolution, which is referred to a camera's ability to spatially resolve two sources of radioactivity as a separate point item. Limited spatial resolution results in the PV effect. PV referred to the fact that a pixel includes a mixture of signals coming from different sources, and it's affected by two parameters, imaging system and the imaging sampling. Owing to the image blur introduced by limited spatial resolution, the signal coming from a point source will be detected not only in one pixel but also in neighboring pixels. When considering a functional structure of interest, part of the activity from the structure will thus also be detected outside outside of the VOI drawn around the structure, and that is called spill out. Conversely, activity from the structure close to the structure of interest will spill in to the structure of interest, and that is called spill in. You can see here because of the spill out result in estimating reduced activity in a region that has a higher activity than its surrounding. Spill in result in overestimating activity in a region that has lower activity than the surrounding. You can see here due to the sampling also affect your SUV. You can see when the sampling is 4 mm, the SUV is 2.7. When it becomes 6 mm, then SUV becomes 2.5 reduced. This is the example where with the, this is the image which is reconstructed without PVC. And you can see here the SUV in the pre-therapy and the post-therapy remains same. It shows that the disease is stable. This is the image where we applied the PVC for the reconstruction, and you can see here the SUV values is increased after the therapy. It shows that this disease is progressive, it is not stable. So you see how it playing a very important. Reconstruction algorithms also affect your quantification. You can see here the when we and it change your SUV values. This is the second example where you can see when we reconstruct the image by using OSEM, PSF, and time of flight, then your SUV is increased. Then it becomes 3.97 to 4.44. Now, time of flight also affect your image quantification. You can see here, this is the annihilation taking place here, and the distance between these two detectors is D. So this detector detects this annihilation at time T1, and this is at time T2. So both gamma camera and both gammas travels with the speed of light. So difference in time of detection by these two detectors is 2T2 minus T1. And emission origin at distance is D. So where D is T2 minus T1 multiplied by C by 2. So but uncertainty is determining time is delta T. So therefore, also the uncertainty in determining D is delta D. So you can see here, if you know that T, delta T, you can calculate the uncertainty, and that is 9 centimeter. So if your resolution, by decreasing the timing resolution, you can reduce the uncertainty, that is your delta T. So this is the example where we have not applied the time of flight, showing a SU values higher than the image which is reconstructed by using the time of flight. This is the example where the patient is lean. Then you see there is no much difference between the non-TOF and TOF reconstructed image. But when patient is heavy or heavy patient, then non-TOF reconstructed image showing a less contrast compared to the TOF reconstructed image. So in summary, the quantitative analysis has been present, nuclear medicine from its inspection, quantitative methods that use disease as a linear process and correlate well with degree of disease. Quantification is very important, in fact, to assess the efficiency of new drugs and treatment. Approximate reconstruction and compensation method often provide good approximate quantitative accuracy in inspect. Deterioration in quantitative accuracy with decreased object size when objects below 3 times of the spatial resolution of the system are imaged. If used standard reconstruction package from manufacturer need to be sure reconstruction is quantitatively accurate. Thanking you. Hello.
Thank you so much, sir, for such
Hello.
a nice, elaborative and interesting talk.
And I'm very sorry because of this. I'm sitting in the desert and there is a problem in the
no problem, sir. No problem, sir.
And
Somehow
thanks to Dr. Rajni and Dr. Arun for giving me opportunity to speak on the AFOMP platform, and to and audience also to keep the patience. Thank you very much.
Thank you so much, sir, for being with us. Even on the holiday, you make us possible to be with us. Thank you very much once again for such an interesting and elaborative talk. Now we have Mr. Ashish Kumar Jha with us. He's one of the renowned medical physics, nuclear medicine practitioner. He's scientific officer E in Tata Memorial Hospital, DAE, Government of India. He's a postgraduate teacher and fellow to Indian College of Nuclear Medicine, chairman to scientific committee of CNMST and NMPAI. So I welcome you, sir, once again to the AFOMP school webinars. So we are sure that that we will be happy to have you with us in this platform. So we can have your presentation now.
Sorry, do you have time for questions?
We do have time for questions. Like we are lacking, means we are running behind the schedule, but still we can have 1 or 2 questions. But we haven't find any sort of questions in chat box yet.
So I have a question on the last presenter. Please, if you allow me, I can ask just one simple question.
Please go ahead.
Okay, thank you so much. So you have talked about the standard uptake values. Now, we have seen that it's being affected by so many factors. One of them is reconstruction algorithm that is being used, whether it is time of flight or same. And then you have also seen the bedtime and also the field of view. Now, would you still say that SUV alone would be the standard measure, for example, to determine the presence or maybe a disease using the PET-CT or SPECT-CT? So I'm asking this question from Nairobi, Kenya.
Hello, Mr. Kapis. I think we have lost Dr. Kheruka from the participant, as he was already on some holiday. So somehow, can I ask Dr. Pankaj or Dr. Ashish Kumar Jha sahab, can you comment on this? Hello?
Dr. Rajni, am I audible?
Yes, yes.
Actually, I didn't hear his question completely. Can I request him to repeat?
Yeah. Mr. Kapis, can you repeat the question, please?
So the question is, we have seen there are so many factors affecting the SUV. One of them is the construction algorithm that is being used. Some of them are the noise level of the imaging equipment that is being used. Others, he has stated, for example, field of view. So would we still say that SUV alone as a standard of measure is the tool that we can use to determine, for example, the presence of a disease or using the PET or a SPECT-CT image, or maybe to determine the progress of therapy? Is there any other tool that we could use other than the SUV?
I believe that mostly SUV max was being used, but nowadays like TLG and peak SUV and average SUV, these things are also being used for prognostication. Obviously, that when we calculate SUV max, it's just depiction of maximum activity in a voxel. So it really doesn't give very prognostic indicators. But if you use peak SUV, which see the surrounding around the pixels, around 26 voxels, and then it is calculated, that may be the better prognosticator. Another is TLG is being used now, and I think that might be the better prognosticator for that. And that's why this talk, in my talk, we will be a little bit discussing about radiomics, which is another paradigm of quantitative imaging, and people are looking very positively towards that. Hope I have.
Okay, thank you. Sorry, thank you so much for the response. Now
this would have other details you can do. You can do question and we can ask the speakers that you were about that. Okay, Mr. Hello.
Sorry.
Mr.
Yes.
Is that okay?
Rajni, your voice is
ready.
cracking actually. Dr. Rajni, your voice is cracking.
Hello.
Ashish, you can start now, I think.
Okay, thank you, sir.
Yeah.
First, I would like to thank AFOMP for giving me this opportunity, and Professor Arun and Dr. Rajni. And today I'm going to speak the role of artificial intelligence in precision oncology. This is a kind of new paradigm for medicine and oncology, and for medical physics as well, because I believe that medical physicist has capability to implement artificial intelligence in medicine and oncology. And
Yes.
yes, yeah. So I believe this is one of the sweetest challenge for a medical physicist to accept to implement that artificial intelligence in oncology. So this we are going to discuss this topic under these headings. If you see that two cartoons, cartoon A and B, there might be two scenarios of implementing of artificial intelligence in medicine or oncology. So hope it should be B1, which is AI assistive to that our treatment algorithm. So let's discuss that each topic one by one. So when we talk about artificial intelligence, then we cannot forget few people, that John McCarthy, who was the first person to coin that term artificial intelligence, and that another person, Vannevar Bush, he first time in 1946 proposed that a machine can think. And the very important person in this chronology is Alan Turing. I think most of us must be aware about Turing test, and he was a genius. And at that time, he proposed that can machine think, and that was taken very well. And his paper was published, that computing machinery and intelligence in mind, in 1950. If you see that the artificial intelligence, that is process to develop an intelligent machine which can replace or outperform the natural intelligence of human being. So it consists of mainly machine learning as well as big data. If machine learning, we'll see in next slide. If we consider that big data, it stands for 5 B's: that velocity, verity, volume, veracity, and values. So if we see that 5 B's and we consider data produced in oncology or in medicine, then you will find that we satisfy all the 5 B's, and we can implement artificial intelligence on that data and use this very novel technique for the assistance of patient treatment in oncology. So if you see that prediction analytics, that machine learning is the method in which the machine learns from the past event and data without being explicitly programmed for that. What happens most of the time, computer works, we give a particular kind of programming, and based on that program, computer acts. But in artificial intelligence, there is program, but that program is not explicitly performed to do a specific task. Say, let's take an example of simple logistic regression, and logistic regression can be applied for many kind of problem. The same algorithm can be applied to predict that particular, with the help of some input value to predict some output value in medicine, in engineering, in language processing, in many other ways. Then ML can be of three types: supervised learning, unsupervised learning, and semi-supervised learning. So major ML techniques can be categorized in three groups. One, regression, where linear, logistic, and k nearest neighbor, these are the mostly we do regression with this. And then decision trees like random forests, classifier, support vector machine, Bayesian network. These works in the principle of this decision tree. And then deep learning like convoluted neural network, recurrent neural network, and artificial neural network. See the pipelines to implement the prediction modeling in any field, say in the case of oncology or medicine, then we have various kind of data, clinical data, imaging data, pathological data, and genetics data, and we have that data. Now these data make the big data, and we need to arrange that data, clean that data. So cleaning, the first step of prediction modeling is cleaning of your data to make the your data amenable to machine learning. And then you have huge amount of data now, and it is very difficult to have prediction model based on that. There are two major issues with that data. One is redundancy of data. Suppose you have two features, and both the features are having same kind of prediction for prediction endpoint. So that is called redundancy. So redundancy you have, then you have multidimensionality of data. If you have so many features based on that, you want to develop a prediction model, and you have a limited number of say case based on which you want to train your model, then there will be difficulties. So in that process, we use first we remove the redundancy. Then there is two technique. One is data selection, and in data selection, what we do, we select the features, best features for our prediction questions. Second is reduction of data. Reduction of data may be performed by using like you have say hundreds of features, and you just aggregated the feature and made the three features out of that. That is called reduction of features. And reduction of feature mostly we do with the help of principal component analysis. And in feature selection, we have various methods, like we have filter method where we use we can use any statistical algorithm like hierarchical clustering and hierarchical clustering, and simple this regression to find out that which is having correlation with each other. Then second step is recursive feature and elimination or lasso. There are various techniques which can be applied. Once you have selected the adequate model, then you have various kind of algorithm, and you never know that which algorithm will work better for your prediction endpoint. So we developed several models and try to validate that model based on our internal and external data, and then we select the best model which is giving you best result for your question. Let's understand about precision oncology. If you see that oncology itself, so it happens like patient comes to us, we diagnose it, then we do the staging, and we select a particular kind of treatment, and we give that treatment, and do the monitoring of the patient, then follow up of the patient. And sometime during the follow-up, you might see that there is recurrence of the disease, and then you do re-staging of the patient, again treatment starts, and then you follow up the patient. But in precision oncology, we believe that there might be some, there's all same treatment doesn't fit for all. So our patient is not having only that disease specific. So each patient in the same disease group might have different kind of characteristic. So identification of that characteristic based on any method like by imaging biomarkers or biomarkers, and we treat that, we categorize that patient in several subgroups and give that specific treatment. One example is say take an example of non-small cell lung cancer. And if patient is GFR positive or negative, if the patient is positive, then we can use various tumor specific antibody therapies for that patient. And if you see that implementation of prediction, implementation of precision oncology, so currently we are treating like this historically, or currently we are treating with organ-based treatments. Say it is lung cancer, so we give treatment for lung cancer. And very recently we have started getting several kind of biomarkers or imaging biomarkers. Based on that, we categorize the patient. And but it is not able to divide your patient properly. So then again, with the help of genomic and radiomic data, you can subdivide the tumor, and you can identify few people in a group which can be treated by a specific kind of therapies. But ultimate goal should be to identify the particular patient, and then only we will be able to achieve the personalized treatment in oncology. And that can be achieved with multi-omics driven approach and implementing decision support system in oncology. One very nice study was performed by Accenture in a few years back. They surveyed with 130 oncologists. Most of them were surgical, medical, and radiation oncologists. And they found that more than 80% wanted to implement that this precision oncology in their treatment, but they found really there is a problem. And in their study, they found that adherence in the precision oncology is very less. Only 14% routinely participate in molecular tumor board. Only 18% routinely use the clinical decision support system, and only 41% routinely match target therapies to genomic alterations. So they recognize this is very important aspect which to address these challenges, which will improve the implementation of decision support system in oncology. So let's discuss about little bit about radiomics. It is quantitative imaging techniques. So what is the pipeline of radiomics? We have medical images, and that medical images retrospectively or prospectively can be collected, and then you segment the tumor, or with that tumor we extract the radiation, extract the radiomic features, and with the help of that features we develop a prediction model to do the prediction modeling. Another very important aspect in the process of this implementing artificial intelligence in medicine is natural language processing. Why it is important? Because it gives you quick look of your data. You can process your data very fast, because majority of data are present in the form of pre-text, and if you want to mine that data and make it amenable to machine learning, then natural language processing is the way to go forward. So there is a pipeline which is being used for this. So if you see that first in this natural language processing, pre-processing, like segmentation of your data, stop word removal, tokenization, and word normalization, then synthetic analysis. So synthetic analysis includes that synthetic parsing, part of speech tagging, and chunking of those data. Then semantic analysis, NER extraction and concept recognition. Then next step is negation detection. So there might be some negative term in your result, and you negate, you detect that negation. Then collection of NLP features and vectors for labeling, and then feature processing. That might be rule-based processing or machine learning-based processing or hybrid processing. So when we say that rule-based processing, we have some set of rule based on that. We do the feature processing, and most of the time it is better to use the hybrid technique. Then you have model development to define the outcome and generate the annotated corpus, technique selection, algorithm development, and training of model. Then model validation, it may be validated internally, and external validation is important if you want to have scalability across the world. Then you have model implementation, classification, decision support system, treatment outcome, and text report generation can be the different kind of paradigm which can be used, which can be where that NLP can be applied. So let's understand that implementation of this infrastructure in oncology, infrastructure in oncology. So if we see that majority of hospital is not having proper infrastructure to implement artificial intelligence in medicine or oncology. So if we see that we have different kind of data sets, like clinical data sets in free in the form of free text, then you have DICOM data set and headers. Then you once you are doing radiomic extraction, then it is thousands of features are being generated. So these features can be extracted from there, and then it should be stored in particular format, in particular place from where that it will be accessed by the researchers, or it can be accessed by various partners for implementation of artificial intelligence in oncology. So in this image, you can see that we have developed a pipeline in our hospital which can extract the data from our HIS or EMR and convert it to in that we say that I'm able to that RDF format, and stores in the SPRQL endpoint. Why this is important? Because if you see that research required, the amount of data required in to implement that artificial intelligence medicine, it is huge. And if you want to make an scalable model for across the world, then you should have data from all corners of the world. But at the same time, there is problem of data sharing because of various ethical and regulatory norms followed by various countries. So other way to take up that challenge or meet that challenge is the distributed learning. So that infrastructure one need to develop. That distributed learning is nothing but data stays in a particular location or specific location. Say, suppose there are three or five centers which are participating in machine learning problems. Then their data will stay in their hospital, their center itself, but that algorithm will move from one center to other center and learn from the data, and then weighted a comprehensive model will be developed, and that will be again tested on that particular data, and a final model will be developed which will be working for all the partners, or for all that, and that will be having scalability across the world. Then what are the trends in implementation of artificial intelligence in oncology? If we see this curve, this was, if you see the trend of CT scan, increasing CT scan and biomarker and imaging biomarker, and you will see that after 2005-06, there is tremendous growth in this field, that artificial intelligence. Recently, we published an article in Nuclear Medicine Communication, and we have seen that from 2015 there is rapid increase in that radiomics-based paper and in oncology, and it is being accepted across the group. So let's see that examples of some clinical examples. So in this paper, a machine learning based clinical decision support system to identify the prescriptions with high risk of medication error. So in this, they have concluded that with the help of machine learning, they can predict that where that prescription is can go wrong. In the next paper, that risk prediction model of lung cancer, here that it has been this paper has reviewed that prediction model used in lung cancer, and they have concluded that there is significant evidence to use the prediction model in the management of lung cancer. This is another paper, and this paper has been published from our group from Netherlands, and this you can understand that the way artificial intelligence is being adopted in that oncology, that this paper is having citation of more than 3,500, and this paper is very well depicting how that there you can develop a phenotype based on imaging data, which can decipher that underlying genotype of the disease in lung cancer as well as in head neck cancer. So in this paper, that artificial intelligence-based clinical decision support system in modern medical physics, selection, acceptance, and commissioning and quality assurance, it has been shown that how a medical physicist can help in implementing artificial intelligence in oncology. So another very important paper I would like to cite here, that role of artificial intelligence in screening cervical cancer. So if you see that with clinical examination, they were having chances to diagnose that to predict that this patient will develop that cervical cancer is only 50%. With the help of pap smear and visual inspection, both it increases to something around 69 to 71%. But if you use the automated evaluation of this with the help of machine learning algorithm, then your this accuracy of detection increases as good as 91%. So there are some challenges in implementation of artificial intelligence in oncology. So in this paper, they have enumerated that various aspects where that labeling of annotating of data is very tedious task, that which can be taken care of by implementing NLP in your algorithm. Then segmentation, suppose you want to do radiomic analysis, then segmentation is very difficult task. So say I want to have around say thousands and thousands of images to develop a radiomic signature for particular endpoint in lung cancer. So you have to segment that tumor, and that segmentation is quite technically demanding. So for that, several automated segmentation techniques has been developed, which can be utilized. Then so second, then implementation of ML techniques, which technique you should use. And recently we have published a paper in NMC that radiomics a quantitative imaging biomarker, and we have enumerated all sorts of techniques which can be used to tackle that shortcoming in implementation of artificial intelligence in oncology. Another very important aspect is that with the radiomics is repeatability and reproducibility. We can generate thousands and thousands of radiomic features, but majority of feature is not stable even on test-retest based basis, and we need to identify with the most robust feature, because if you have developed a model with feature which is not having stability, then this is not going to work for in your future work. So it's always important to have this study of repeatability and reproducibility and find out that most robust feature. In this study, we performed with human cohort and phantom, and we found around hundreds of features have that this concordance coefficient of around 9 and above, and they are the robust feature, and those feature can be implemented. And further study we have used those feature, and they are having very good prognostication. At least we have used for 2 cancer type, cervical cancer and lung cancer, and we found that that importance of those feature in prediction model development. So implementation of machine learning in healthcare, addressing ethical and challenges. So there are 2 major challenges, ethical and regulatory challenges, that need to be discussed and fixed. So there are few groups in Europe and USA where that they have started this developing regulation to regulate this prediction modeling and decision support system, and that is one of the most important aspect to implement artificial intelligence in oncology. So implementation of CDS, how it will be implemented. So we can understand from here that suppose one patient comes to you, then you have various kind of investigation to perform. So once you have performed the investigation, you have this clinical decision support system based on radiomics, based on clinical data, or with multi-omics, and then we use that that platform to give you some sorts of direction how to treat that patient, what to do with that patient. And once you have treated that patient, and the patient comes for the follow-up and see that what is their outcome and whether that outcome is matching with your outcome, predicted outcome or not. If it is then if it is not, then give feedback to that system, and how this is how it makes that self-learning based computer decision support system. And summarize that AI is going to contribute significantly in precision oncology workflow. Radiomic leveraging digital phenotyping of disease linked to outcome may be the breakthrough in imaging. Reproducibility of radiomics, NLP, AI need to be ensured. The medical physicist can play a major role in implementation of artificial intelligence, oncology, and medicine. Then ethical and regulatory issues related to artificial intelligence implementation in medicine need to be discussed in length and width and fix to fix it. Thank you for your patience hearing. If you have any question, I am ready to take that. Thank you.
Thank you so much, sir, for being with us and for such a wonderful talk. Now I will request all the participants, if they do have any sort of question, they can ask directly with the speakers. Dr. Ashish Jha is also there, and Professor Arun is also there. So for any questions, please feel free and write your questions. Okay, I guess we do not have any question. Even the presentation was so wonderful that it was really informative. Even I feel amazed about some aspect that AI is coming so fast in nuclear medicine. So thank you so much, sir. And I want to thank all our speakers for today's AFOMP School webinar. It was a wonderful session for all the people who are seeking some information in nuclear medicine. Now we have Professor Chogle with us. I think he's going to wind up the program. So thank you so much, sir. Please go ahead.
So thank you, Rajni.
Hello.
Yeah, are you able to listen to me? Is it okay? Are you getting my voice?
Yes.
Okay. Okay. So
yes, perfectly.
So thanks to Dr. Pankaj Tandon for organizing this wonderful AFOMP School webinar. And we had 4 excellent speakers. Thanks to Dr. Anshu Sharma for excellent talk. Then Pankaj Tandon himself gave a wonderful talk. And then Dr. Subhash Kheruka from Middle East. He joined to us, and last talk was from the Ashish Jha about the artificial intelligence and things. So thanks to all the speakers for giving a insight into the topic they have chosen and given huge amount of knowledge to us. Thanks to all the participants for joining and taking interest in this AFOMP monthly school. Thanks to all my AFOMP ExCom, Jin Xians, the chair of the ETC, Chai Hong, chair of the PRC, Rajni Verma, and everyone. As you know, we will have the next AFOMP school webinar on 26th March 2022, and this will be on the actually leadership in medical physics, how important this is, and Carmel Karuna will be speaking on this thing. Already on the AFOMP website, the information is there. You can log on. And also we have in the month of April, in the month of March, we have another meeting on Friday, that is the 4th, and then we have upcoming the AOCMP 2022 in Taipei, Taiwan during 10 to 12 December, IUPACM World Congress in Singapore during 12 to 17 June 2022. The abstract submission is on. If you are interested, please do join. So once again, I thank all of you, all the speakers, Dr. Rajni Verma for moderating excellently, Dr. Jin Xian, Chai Hong, and everybody. And this actually the AFOMP school is ACPSM CPD accredited, and you will get 6 points for this and certificate for the attendance. With this thing, thanking each one of you, we close and we'll meet on 4th of March for AFOMP school, and then 26th March for the AFOMP webinar. So have anything
So
you want to?
I have to say something. Actually, we have some question and queries related to certificates. So the certificates for AFOMP school program we have started now only. It was not there earlier. So you will be getting certificate now onwards, not for the past AFOMP schools. So you can write to Dr. Chai Hong directly for the certificates for today's AFOMP school webinar, not for the past ones. So I think this will be helpful to the people who are looking for certificate and asking for the certificate. If any question related to certificate is there, please you can ask us now also, and you can write to us also, and you can directly write to Dr. Chai Hong also. So thank you so much all, and
thank you, Dr. Chogale and Dr. Rajni, for all the wonderful session conducted, and I'm really thankful for giving us an opportunity to be with this AFOMP school this time, and hope to get
pleasure, sir. Pleasure, sir.
Thank you very much, all of you.
We have this.
Good. Okay. Thank you. Thank you. Bye bye.
Thanks, Arun sir and Rajni madam. Thank you so much.
Thank you so much, sir.